continuing with our condition series, we've got cerebral metastases. Your curriculum doesn't talk about anything other than cerebral metastases. It doesn't talk about primary brain tumours, but obviously we need to consider them when we think about cerebral mets. So brain metastases or cerebral mets are the most common tumour of the central nervous system that is malignant. And depending on where the primary tumour is, up to 40%, so nearly half of people with cancer may develop them throughout their presentation. And that gets more likely as people live longer with more effective treatments with cancer. And people may actually be diagnosed with their cancer, irrespective of where its origin is, lung or breast, for example, because they have secondary brain deposits which are symptomatic. So if somebody has a seizure, for example, they may have imaging, find cerebral metastases, and then the primary cancer is found. So there are some cancers that are much more likely to spread to the brain. Lung is very common, then breast, melanoma, kidney, testicle, then thyroid. So those are the ones that we think of as very typical. Some of them have very distinctive appearances as well. For example, melanoma is quite necrotic and tends to bleed. In around 15% of people with cerebral metastases identified, we don't know the primary tumour, and we may, in some cases, not find it at all. So again, like any sort of lesion within the brain, the features depend on where the cerebral metastasis or metastases are. So if it's in the motor cortex, you might have a hemiplegic weakness. If it's in the occipital lobe at the back of the brain, which coordinates vision, you might have visual field issues, behavioural changes in the frontal lobe, incoordination and ataxia in the cerebellum. Obviously, if there are lots and lots of different lesions, you might see a lot of symptoms. So if people have lots of neurological features, are unwell and have headache and signs of raised intracranial pressure, suspect multiple intracranial lesions and do prompt brain imaging. Around 20% present with a seizure, and around half, when they're then examined, have some neurological deficit on examination if they have cerebral metastases. And the headache's due to raised intracranial pressure. People assume that the headache from raised intracranial pressure from a brain lesion is very bad. Often patients can describe it as quite mild. They say that their headache is quite bad first thing in the morning. Obviously lying down, they have greater pressure. They get up, they have a paracetamol, and they go about their day and can manage quite well. You would also expect the headache to get worse on straining, coughing. You know, people go to the toilet and strain and can be worse. And if they do have visual changes, you must look in the back of the eyes to see if the optic discs are swollen. That's really important. It's a fundamental part of neurological examination. So in terms of investigation, if you have multiple tumour deposits in the brain, it's much more likely to be metastases. So a primary brain tumour, it tends to be a single larger lesion. Other things that can give you multiple lesions that can mimic metastases are central nervous system lymphoma or toxoplasmosis. Toxoplasmosis is pretty rare unless somebody's immunosuppressed. So if somebody is newly diagnosed with AIDS, which is untreated, or they have quite profound immunosuppression for other reasons, toxoplasmosis is more possible. Single lesions could also be intracerebral lymphomas. We've talked about cerebral abscesses before, or tumour factive, a big area of multiple sclerosis, a big area of inflammation. That can sometimes be mistaken for a brain tumour. Lesions tend to light up on MRI with contrast. They tend to have lots of edema around them. They cause swelling of the surrounding brain because they're quite irritant. And sometimes you can have some bleeding within the lesion. And there are also some other imaging modalities, imaging techniques within MRI that can help identify chemically what the lesion is. So we call that MR spectroscopy, and surgeons do a lot of MR spectroscopy to try and identify what kind of tumour something is before they go in for surgery. And sometimes surgery isn't possible. So in terms of treatment and prognosis, when we find that somebody has metastases, it's really important to do examination and investigation of the rest of the body, looking for the source of the tumour. So we tend to do a CT chest, abdomen, pelvis. There are some areas that aren't captured by that, so you need to do a breast examination in women, testicular examination or prostate examination in men, examination of the thyroid with a neck examination to look for the primary. And then treatment plans depend on where the cancer is and how advanced it is. If we do not find the source of the cancer, then we can do what we call complex functional imaging, like a PET scan, and that looks for areas of high activity in the body. So we give somebody radio-labeled glucose, and we look for areas of high glucose uptake, because cancers like to use up a lot of energy in trying to spread. So we look for hotspots. We do not do blind cancer treatment, so oncologists are always very clear that they need to know what they're treating before they start to treat. If it's not clear from the multidisciplinary team, a biopsy of the lesion of the cerebral met sometimes can tell us where the tumour has come from. So on occasion, if there's a single met in the brain and it's not been possible to identify where that tumour has come from, there's only 1 or 2 lesions, then sometimes the neurosurgeons will take a sample or excise a sample from the brain, and we can see that actually this comes from the lung, although we've not been able to find it in the lung itself. So in the immediate presentation, if somebody is very symptomatic with weakness or seizures, high-dose steroids, dexamethasone, can reduce pressure from the swelling and improve the symptoms. And if there's a good prognosis, if someone's found to have maybe breast cancer with a good likelihood of cure with excision and with chemotherapy or radiotherapy, 1 or 2 brain metastases may be possible to resect from the surgeons. The mean age of survival, however, if somebody's found to have cerebral mets, is on average 1 year or less, depending on where the tumour is from and how advanced the cancer is, and whether or not the oncologists are able to provide definitive treatment.